Alrighty, folks. We got a jam-packed 20 minutes for you. I'm Greg Wu. I'm an emergency physician and medical intensivist up at Albany Medical Center in Albany, New York. And today we're going to be talking to you about 5 trauma critical care papers. These are 5 papers you can take back to your trauma bay tomorrow and implement practice right away. I have an excellent team up here with me. We're going to go rapid fire, talk about some papers that I think that are going to be really relevant to you. I'm the Critical Care Interest Group Chair, and I practice 50% emergency medicine, 50% medical ICU, but I am still in that trauma bay every single day.
Hi, I'm Luke Duncan. I'm the Chief of Emergency Critical Care at Albany Medical Center. I'm a surgical intensivist by training, as well as an ER doc. I work in both places. I'm also ECMO Medical Director. I do HEMS, and I'm the trauma representative for our department.
Hey everyone. My name is Mitchell Zekhtser. I'm an anesthesia critical care fellow at UCSF, and I'm also an emergency medicine attending out in the community, so I get to practice a little bit of both. So the first paper we're going to talk about, I think, is the most interesting, but before we get there, I want to say we have no financial disclosures to talk about.
We're definitely still very poor emergency academic physicians.
Completely broke.
Sure.
Well, I'm very affordable too, so if you got sponsors, I'm open.
So, as I said, I think this paper is the most interesting to me because it kind of changed as I was practicing emergency medicine throughout residency. And it is written by Colatano et al., and it's the small percutaneous catheters versus large chest tubes for traumatic hemothoraces. And this is a multi-centered randomized clinical trial. And there was a very specific question that they wanted to answer, and it was kind of expanded upon from previous papers in the past, and it doesn't matter. Do patients with traumatic hemothoraces and small chest tubes, is this inferior to large chest tubes? It's an unblinded block randomized trial that looked over 5 different centers with about 120 patients. It got cut down because of COVID, so they had to publish out the data earlier. They included all patients that were over 18, and if the patient was hemodynamically stable. If the patient was not hemodynamically stable, they just did a surgical chest tube. And if the patient didn't want it, or if the surgeon didn't want to do this. So they broke it down into 2 groups. About 56 patients got a percutaneous chest tube, and about 63 got a regular surgical chest tube. The primary outcome was, did you need to do something else? Did we need to put another chest tube in there? Or did the patient need a VATS? What they found, there was about 11% failure rate with a 7% conversion to VATS in the pigtail group, with a 13% failure rate and about a 5% conversion to VATS in the surgical chest tube group. The most interesting part of this paper and what they were really looking at is something called the IPE score, which is really called insertion perceived experience, and that's a weird way to say, does that hurt? So a 1 meant it doesn't really hurt, I'll totally get another pigtail, and a 5 is that was the worst pain of my life, I definitely don't want this. And as you can see in the surgical chest tube group, it was about halfway through, it was really bad, I don't want to do this again, and in the pigtail group, they'll probably do it again. So what are the take-home points here? A 14 French chest tube is non-inferior to a 28 to 32 French chest tube when it came to incidence of failure, clotting, anything like that. And smaller chest tubes caused markedly less pain during insertion, which I think is really important. And the best part about it, this paper was written by surgeons, and they recognize that their patients are not feeling very good, and they want to do something differently about it. And if it was up to me, I'd also want a pigtail.
It's a great paper, Mitch. Great job presenting. I like this paper because it's really dogmalytic. Pretty much every surgeon that I work with would rather put in a 32 French chest tube than anybody with a traumatic hemothorax. But what if I told you that you may not actually need to do anything with a traumatic hemothorax or pneumothorax? So this paper by Walker et al. Looked at the conservative management in traumatic pneumothoraces. So essentially what they sought to ask was, what predicts the need to place a tube thoracostomy in? So why do you need to put a chest tube in? What causes people to fail? It's a prospective cohort study based out of Europe. Out of the TARN database, it's a fairly large collection of 7 trauma centers, and it's a registry database. So they found 277 patients that underwent conservative management, and they had 325 as the comparator group that had an immediate chest tube placement. They put them into people, they tended to be male patients that were hemodynamically unstable, that had a larger pneumothorax. The mean size in both groups was about 22 millimeters. They had a hemopneumothorax that would get them a surgical chest tube immediately. If they were stabbed, they definitely got a chest tube. That's definitely a surgical dogma. And if they were on positive pressure ventilation, they tended to get an immediate chest tube. So what about the outcomes of the people that were managed conservatively? Well, only 9% of patients managed conservatively ended up needing a chest tube, which is actually somewhat low. Interestingly, the predictors of failure was mainly hemothorax. And it's not clear whether that was just because they were trying to drain a hemothorax or if there was truly a failure of that conservative management. But positive pressure, and this is a really interesting point, did not predict the need for a chest tube or failure or expansion of that pneumothorax. And certainly all of us with patients that have a pneumothorax that are intubated as a trauma patient, you tend to put that in. So interesting. So take-home points. Watch and wait might be the right way to go. Sometimes just putting your hands in the pockets instead of doing the tube may be the right thing in patients that you are selecting appropriately. So those are hemodynamically stable with simple, small pneumothoraces, under about 20 millimeters at the apex. And positive pressure ventilation, you sometimes can watch these patients and see. So you may not need to put that chest tube in immediately. But certainly, if at any point they develop respiratory distress, I'm certainly going to poke them in the chest, okay, and put that tube in. And I may choose to put in a pigtail. If they're stable and everything's going fine, I may choose to put in a surgical chest tube.
Alrighty. So I think what we're kind of starting to see here is maybe we don't need to do big chest tubes anymore for hemothoraces, and maybe we don't even need to do chest tubes at all for a simple pneumothorax. Well, that's a pneumothorax. What do we do about bleeding? Is there any new literature on bleeding? We're going to next talk about the CRASH-3 trial. If folks who may or may not remember, there was the CRASH-2 trial back in the early 2010s. This was a large double-blind randomized controlled trial that showed that 1 gram of TXA was very effective at reducing hemorrhagic death. And like any good series, you need a trilogy, right? If there's a CRASH-2, there's got to be a CRASH-3. This is the return of TXA. So this is from 2019, and the investigators sought to answer the question, does the routine administration of TXA in patients with a GCS of less than 12 or have a known intracranial hemorrhage, does that reduce the risk of head injury-related death? And these are all the words that you want to hear in a randomized control trial. It's double-blind, placebo-controlled, multi-center, multi-continent. This was Africa, Western Europe, North America, all big places. Big trauma centers, little trauma centers, rural systems were all participating in this study. Patients were randomized to either receive 1 gram of TXA over a 10-minute load with a 1 gram 8-hour infusion versus a saline placebo. Patients had to have either GCS less than 12 or intracranial hemorrhage, and they could not have other major traumatic injuries or hemorrhagic injuries below the neck. So these were really head injury patients. They picked their patients very specifically. And despite that, they still were able to recruit a lot of patients. They recruited over 4,600 patients into the TXA arm and just over 4,500 into the saline placebo arm. Randomization was good. Table 1 showed that these were very similar groups together. And what did they find? They found there was about an 18% head injury-related death at 28 days in the TXA arm versus about 19% in the saline placebo arm. Really about the same. Not statistically different, not clinically different. Really no benefit of giving TXA routinely. Well, they have close to 9,000 patients. There's got to be a subgroup analysis, right? And of course there was. What they showed was if you factored in only patients who had bilaterally reactive pupils, meaning that if you had 1 blown pupil or 2 blown pupils, you got excluded from this analysis, they showed that there was a benefit to TXA. It was small, about a relative risk of about 0.87 if you had bilateral reactive pupils and you got TXA. The other interesting thing in the secondary analysis was there was no increased risk of adverse events, including stroke, pulmonary emboli, thrombosis, MI. And this is really consistent with the TXA literature. Whether it's for a nosebleed or for trauma, it doesn't seem that TXA increases thrombotic risk. And I won't go too much into the molecular mechanism of why that probably is true, but this seems to really hold true that TXA is a relatively low-risk medication when we use it. They also show that giving it after 3 hours did not increase mortality. And this is a little bit different than CRASH 2. This is a little bit hard to know what to do with. Is this a statistical fluke? Was a 3-hour statistical fluke? But it says that, at least in the head injury population, we do not have to worry about giving TXA late. So what do you do with this information? What's our take-home point? The first is that TXA, when given routinely, does not benefit all patients with traumatic head injury and isolated intracranial hemorrhage. That this is not should be where we're devoting a lot of energy. There does seem to be a little bit of benefit in patients who are less severely head injured, but really what we need is a randomized control trial. We need to go back and look at this group in the same way that we looked at less than 3 hours for in CRASH 2. What happens if we include patients with bilateral reactive pupils only and with less severe head injury? So I would say that this is not something that I'm reaching for right away in the trauma bay. I'm not devoting a lot of energy. But if we're giving it, then I'm knowing that's not directly causing a lot of harm to my patients who have head injuries.
Thanks, Greg. Well, you know, that's kind of a bummer. Thought it was going to be a lot more bigger for bigger bleeds, but what about REBOA? REBOA, obviously everyone's doing in every single trauma bay. Just kidding. No one's really doing that as much. But just as a reminder what REBOA is, it's a resuscitative endovascular balloon occlusion of the aorta. This paper, written by Castellani et al., tried to do a systematic meta-analysis of all the papers that are out there to see whether or not REBOA can do something for our patients. And the main question that they had is this: does REBOA catheters, and do they, reduce mortality for patients that are exsanguinating from torso trauma? As I mentioned earlier, this is a meta-analysis, and they looked over 300 different papers. There were no RCTs that they were able to find, and they narrowed it down to 11 studies, observational studies. Question being, does REBOA reduce mortality versus resuscitative thoracotomy? 5 papers were looked at, and they did find that in those papers, those patients did have decreased mortality. It may have been a little bit of bias whether or not those patients were a little bit more stable, whether or not those patients actually had cardiac arrest, were they peri-arrest. It was a little difficult to tease out, but they found that people with REBOA did better than resuscitative thoracotomy. They found one study that was REBOA versus resuscitative thoracotomy and REBOA. They're like, let's just double down and see if that helps anybody. They found that resuscitative thoracotomy and REBOA did worse than just REBOA alone. And they looked at the final paper, or the last 5 papers, and what they found was maybe, maybe not. REBOA versus no REBOA, there was no statistical significance in this group of patients that whether or not these patients do any better. So what are the take-home points here? Well, you need a randomized control trial, and that's really difficult to achieve in this patient population as these are really critically ill patients. But REBOA may be better than resuscitative thoracotomy in patients that are peri-arrest, hypotensive, a little shocky, but not expired. However, it's not clear if REBOA is better than anything at all. And what we really need is a randomized controlled trial to really assess this and see what patients can truly benefit from this procedure.
All right. So, Mitch, great paper. Again, I'm not sure how many people in the room have seen or experienced REBOA. It's a fascinating modality, but certainly it is not ready for prime time, in my opinion. So, finally, this is a brand new paper. It just came out in January of this year. It was presented, actually February of this year. It was presented at the Eastern Association for Trauma. One of my trauma colleagues actually texted me this paper as soon as he saw it. He's like, is this the death of ABC in trauma? So, and it's the emergency department versus operating room intubation of patients undergoing immediate hemorrhage control surgery. So what they sought to answer in this paper was if patients that were going to the operating room for hemorrhage control, does intubation increase their mortality? And this wasn't the patient that was obviously needing to go to the, obviously needed to be intubated. This is where it's a judgment call. They've got a GCS greater than 12. They've got maybe, you know that they're definitely going to the operating room regardless. This is where it's a protocol or a judgment-based decision by the emergency team whether they need to be intubated or not. So it's a retrospective cohort study from the National Trauma Database, which if anybody has read any trauma papers with the National Trauma Database, it's a very robust patient-level database where you can get into some very nitty-gritty details. And what they found was they had about 1,900 patients that were intubated in the emergency department versus 7,700 patients that were intubated in the operating room. And the primary outcome was that it was a 10% difference in mortality for patients intubated in the emergency department, which is kind of interesting, right? And it's not just in hospital mortality. These are peri-intubation arrests. These are patients that are dying in front of you during that intubation. It's kind of interesting when they looked at what types of injuries and what types of surgeries these patients ended up getting. The patients intubated in the emergency department tended to have twice the rate of thoracic trauma and needing a thoracotomy and twice the rate of neck surgery, while the OR intubation group was about twice the amount of extremity surgery for hemorrhage control. So they're different cohorts, so it's a lot of judgment call. So maybe intubation in the emergency department is actually a marker for really sick trauma. Maybe that's why patients are dying. And the fear is that, oh, the trauma surgeon is going to take away the ability for us to intubate. No, that's not what they're saying at all. Definitely, we should still be running the airways in the emergency department. We should still intubate patients that obviously need to be intubated. But maybe when it's a judgment call and that patient doesn't need to be intubated in the emergency department, we could hold off, put our hands in our pockets. And the other point I want to take home is proper hemodynamic resuscitation before and after intubation is absolutely key. You can't take RSI lightly. These patients are kept alive by their sympathetics, and you are sympatholysing them as soon as you push that sedative. The final piece of data that came out of this is this variation in practice. Some places 5% of their traumas are getting intubated. Other places, 70% of their patients are getting intubated. There is a huge variation in practice of what we do based on where we work. So you may be able to take this home and say, maybe we shouldn't be intubating these patients that need to go to the operating room. Maybe some of what I can't figure out and what's not written in the paper is where those mortality rates are. Are they higher in the places that don't intubate as much as the patients that intubate almost everybody? So, all right.
Alrighty, I'm going to wrap it up for us and we'll take it home. So what can we take away from today? What are things that you could use in your trauma bay tomorrow? The first is that pigtail catheters are non-inferior to large bore chest tubes when it comes to the traumatic hemothorax. Your patients will be a lot happier. It makes everyone feel better about the situation. Get comfortable using percutaneous chest tubes. And if you don't know how to use them, learn how to use them. Second is a watch and wait strategy for small, uncomplicated pneumothoraces is a very reasonable approach. Some patients will fail, but a lot of patients will not. And a lot of patients will never need a chest tube at all. So for pneumothoraces, without a hemothorax, a lot of times you can manage this just with no chest tube at all. Third, TXA for intracranial hemorrhage is still of uncertain benefit. This is not something that we should be reaching for routinely. There doesn't seem to be a lot of harm, but at the same time, there doesn't seem to be a lot of benefit. Don't spend a lot of your mental energy and time trying to figure out how to get TXA. Fourth is that REBOA may be better than a resuscitative thoracotomy. I'd rather have a catheter than have a hole in my chest, but that may not be better than standard care alone. Focus on good resuscitation. And finally, focusing on resuscitation before intubating patients bound for the operating room is a very key element. Do not be intubating patients just because that's the protocol. Be intubating patients because you're doing it for good reasons and that you've properly prepared the patient for RSI. At this point, we'll be happy to take questions. Yes? I'm sorry, I missed the beginning of the question.
They talk about how long to failure in the chest tubes that did end up failing.
Oh, you're talking about in conservatively managed pneumothorax. I honestly don't remember if there's a number. Do you remember if there's a number? No.
No, there wasn't really a time frame. It was more during that hospital admission, and if they were for the conservative management, it was if they needed a chest tube insertion, and that was just a marker. For the pigtail paper, it was for needing to get VATS performed.
All right. Anything else? Yes.
In regard to that same paper, I think it was released before the REBOA paper came out talking about the 35 millimeter rule. Was that considered as part of that paper again?
No, this was done. It did not include that criteria.
Yeah, but the cutoff, they arbitrarily they found that the average small pneumothorax was 22 millimeters, so certainly under the 35. Yes.
How would you pull back and summarize the current best practice for TXA and what's known? What's a consensus opinion? What's feasible but not yet interpreted from use of TXA?
Yeah. So certainly, I would say that without any hesitation, in my mind, Crash 2 was one of the definitive papers to say that TXA definitely seems to be safe, and certainly for a lot of our hemorrhagic traumas seems to be beneficial. On the other hand, we should also recognize that there are limitations to it as well, and that if it's a head injury, that we should not be necessarily reaching for it right away routinely, that this should be every patient gets TXA. But certainly if patients have multiple injuries, and like a lot of our patients, there's both head trauma and torso trauma and extremity trauma, exsanguination is certainly not good for the brain. I would certainly be giving them TXA. And I think that you'd have a hard time arguing with, or finding people who would argue saying that giving TXA to those patients is not beneficial. So I think the hard part becomes the difference between in a study when we're able to isolate out the head versus what we see every single day when patients come in as polytraumas. So I think certainly TXA is still very much on, still part of the management for a lot of our polytrauma patients.
Just a quick follow-up, but are there any consensus statements on that? I mean, that sounds very reasonable.
Yeah.
Reasonable, but is that your read or is there other consensus?
That's a good question. That's certainly, I think that would be sort of my interpretation of the current literature. If there's other consensus statements, and I may not be aware of them.
In regards to REBOA, stating that it's probably better than the state for economy, did that also include the patient that had a peripheral lesion or tamponade as well?
No, it was really hard to kind of tease it apart. Sorry, it was kind of hard to tease it apart because some of the databases aren't from here, but it did talk about thoracic injury, but it didn't specifically say anything about pericardial effusions or tamponade in general, unfortunately. So for those patients, didn't really dive deep into that. I think you just need to give them more preload to resuscitate them as you normally would, which is kind of what the last 5 papers talked about. Hard to say if there's any statistical significance, and it's hard to say whether or not REBOA is better than conservative management, which is giving them product, blood, plasma, platelets. And especially for tamponade folks, you want to give them preload and then want to decompress.
Yeah, my hypothesis is that you get to resuscitative thoracotomy when you go into cardiac arrest versus REBOA, where you're peri-arrest and very hypotensive. So I think what it is that resuscitative thoracotomy is a marker of people that are dead, and REBOA is something that's you're giving to them pre-death. So I think that's where the difference comes from.
Put more glibly, mostly dead is still partially alive.
Mm-hmm.
Partially alive, it's true.
Alrighty.
That's from The Princess Bride for anybody under the age of 30.
Oh God, did we just date ourselves?
Yes, we did. We're all.
Oh, we're so old.
Greg, you're getting gray hair.
All right, thanks everyone.